Thank you, Chet. I'm really pleased to be here today to take a few minutes to say a few words about intensive outpatient treatment. As far as I know, this is the first event to publicly promote this treatment approach. CareFirst has always been an active supporter of intensive outpatient, and I want to thank Chet and the medical director of CareFirst, Dan Wynn, for further extending this support by organizing this event and this initiative. Drug and alcohol rehabilitation programs work by providing intensive structured group therapy to patients who are abstaining from substance use. The treatment was initially restricted to inpatient settings, but because of progress in the use of medication and abstinence monitoring techniques, rehabilitation can now be done on an outpatient basis. Delivering these services in an outpatient setting provides the same level of effectiveness as inpatient treatment without taking people away from their homes and jobs. Work is done on managing day-to-day stresses in a real-life environment rather than in an artificial protected one. The advantages of outpatient treatment are enhanced when it's preceded by outpatient detoxification and followed by less intensive continuing outpatient treatment. By providing all three levels in a single facility, premature dropouts can be reduced, especially if the treatment phases are designed so that they overlap. This approach not only avoids the initial disruption of inpatient treatment, but also eliminates the reentry transition problem that occurs when people return to their homes after they're discharged from the inpatient treatment facilities. This is particularly important because the chronic nature of substance use disorders makes continuing treatment at a less intensive level of care critical to successful long-term recovery. The lack of follow-through after inpatient treatment is disappointingly high, leading to relapses, repeated treatment attempts, and sometimes death. Expanding access to intensive outpatient treatment is particularly relevant at this time because of the challenges presented by the continued opioid addiction crisis. While concerned voices call out for more treatment beds, I would suggest that more people can be treated effectively if funds were directed toward outpatient rehabilitation instead of toward more inpatient treatment. 4 patients can be treated in an outpatient rehabilitation for the cost of 1 patient treated on an inpatient basis. Inpatient treatment is a necessary level of care for a limited number of patients who require more physical containment, but using it as a default first option for everyone is unnecessary and wasteful. I'll end by mentioning that the intensive outpatient model originated right here in Maryland. The program was designed by myself and my colleagues in 1973 to operate during evening hours to especially meet the needs of working individuals. We later broadened the program by adding morning hours. Over the past 44 years, I've spent my entire professional career working to improve this treatment model, and I've overseen the treatment of 30,000 patients at Colmac. The intensive outpatient model has now become mainstream, and programs are operating throughout the country. Studies have documented its equivalent effectiveness to inpatient rehabilitation. Despite all the advantages provided by outpatient rehabilitation, however, this treatment approach is underutilized. My hope is that this CareFirst initiative will stimulate and increase its use in facilitating recovery and saving lives. And so I'll close by thanking you all again for your support.